Hi, this is Dr. Doug Lucas, the Chief Science Officer of PhD Weight Loss and Nutrition. This is a quick introduction to the video that you're about to watch. The topic of the video is type 2 diabetes and the difference between medical management and potentially reversing or significantly improving type 2 diabetes with nutrition therapy. I think you'll find the literature compelling, and I hope you find the video helpful. My name is Dr. Doug Lucas. I'm the Chief Science Officer for PhD Weight Loss and Nutrition. Talk today is on type 2 diabetes, basically the difference between managing it and reversing it. And I've added some slides on the current coronavirus or COVID infection and pandemic and how it relates to diabetes and why now is probably a pretty good time to be concerned if it wasn't already a good time to be concerned about diabetes. So a little bit about me. By training, I'm an orthopedic surgeon. I still practice. My subspecialty is in foot and ankle surgery. That has exposed me to diabetes more than some of my peers, most likely, because I manage people that are having complications with neuropathy and wounds, and ultimately sometimes requiring amputations. This became more apparent when we moved to Asheville than when we were in Colorado, where I started practice. And that has really pushed me to become full-time science officer for PhD and practicing orthopedics in more of a part-time manner. So this is where the information is going from these talks, and the content is available publicly for anybody who's interested to look at these talks later and contact us with questions. I am an owner of PhD Weight Loss, so that's not the purpose of this talk. The purpose of this talk is really to get this information out and to educate as many people as possible with how nutrition is a better tool for reversal, or is the only tool for reversal of diabetes, versus traditional medical management of diabetes, and how those are different things. Quick medical disclaimer: because I am a physician, I have to say that just because you're watching this does not create a doctor-patient relationship. This does not constitute the practice of medicine. No individual recommendations are made. So these recommendations are not specific to anybody who's watching this, either online or live. If you are going to consider making some changes in medications or lifestyle, you must use your own physician and your own management team to make these decisions. And PhD Weight Loss does not staff a physician. I do not see clients, and I do not see patients through PhD, and our coaches cannot substitute for your physician. So we'll start out with the current statistics with the COVID-19 infection and risk factors. So the situation in New Orleans is expanding rapidly, and early on, there were some clear differences between what was happening in New Orleans versus what was happening in New York City. And they noticed that they had a fatality rate that was almost double that of New York City. And what they recognized is that there are more people with underlying conditions in New Orleans as there are in New York City. The number one identified underlying condition for people that are struggling to recover from this virus is diabetes. The number two condition in New Orleans is obesity. Some published data from New York further clarifies that of the 2,000 people in the study that were hospitalized, almost a quarter of them required ventilation, and there's a relatively high fatality rate at 36%. So clearly that's a group that you don't want to be a part of. The risk factors that they identified, they did not actually mention diabetes, but you can see that BMI over 40 is listed as number 2, with age being number 1. The criteria for admission were based mostly off of age and BMI. So obesity in New York and diabetes and obesity in the South, and we'll see in this talk how those two can be related, obesity and diabetes. If you look at ICU admissions on this study, they mentioned these 4 criteria, which we don't need to get into, but those last 2, ferritin and CRP, are indicators of inflammation, which we know people that struggle with obesity and diabetes have much higher rate of inflammation, and that can lead to worse outcomes that way as well. So when people look online about diabetes, they will frequently go to the American Diabetes Association or other associated government-run sites, and they are big websites with a lot of information. However, the message can be very morbid. If you look at this is on the I think the landing page or one of the first pages you go to under education, and it literally puts diabetes and death in the very top of the slide. And it's saying that it's not a death sentence, but it is usually for life. And that really sounds like you are stuck with this thing and that it is a way that you're going to have to live for the rest of your life. And I disagree with that. But as a medical provider, this is how we're trained. So um, this is out of a medical textbook, and I'm not going to read it. But if you look in that first sentence, it just starts out with type 2 diabetes is a progressive disease. And that's how we're trained. We're not trained to discuss with patients how to reverse it. We're only trained that it is a progressive disease and how do we manage it. And I disagree with that. I think that diabetes should be looked at as a nutrition condition, and it's characterized by having high levels of blood glucose and high levels of insulin. Again, this is type 2 diabetes, but the key to that is a potentially reversible condition. So, right out of the gate, I want to say that we're talking about type 2 diabetes. We're not talking about people that have been diabetic their entire life. The big difference between the two is that a type 1 diabetic does not make insulin. And if you look at the definition there, they have low insulin and high blood glucose, whereas a type 2 diabetic has high insulin and high blood glucose. And that is a clear difference between type 1 and type 2 diabetics. They do blend as a type 2 diabetic, your diabetes gets worse. You may stop making insulin. You may look more like a type 1 diabetic. But there are some differences. So again, low insulin levels for type 1s, high insulin levels for type 2. So diabetes, if we go all the way back to the beginning in the United States, was really not a problem until the last couple of decades. Back in 1893, when Dr. JOSLIN, who literally wrote the book on diabetes, studied it as a medical student, he found a prevalence, meaning the number of people that had it in that area where he was studying, of less than 1%. In 2015, it was more like 15%, and I can tell you that it has not gone down from 2015 to 2020. It's much higher. Estimates of 38% of the American population are pre-diabetic. These are people that are diagnosed. I've seen estimates of undiagnosed. It's more like 2/3 of the American adult population are pre-diabetic. Total cost to the U.S. of $327 billion. And that was in 2017, and that number just continues to go up. So we're taught that diabetes is progressive because ultimately it is progressive. If you look at the history, people that are diabetic after 9 years, less than 25% are still on one medication if you follow them chronologically. After 10 to 15 years, over half of those patients will require insulin, meaning that their diabetes is just continuing to get worse and get worse and get worse. And that's why we call it a progressive disease. Why is diabetes a big deal? Well, other than the fact that you have to manage it medically, if you look at our top 10 rates or top 10 causes of death in the United States, diabetes comes in at number 7. But I would argue that it is related to heart disease very strongly, kidney disease, stroke, cancer, and Alzheimer's. And I would also argue right now, you could say that it's related to respiratory diseases. It's related to influenza, likely related to mental challenges, and potentially suicide. So other than unintentional injuries, diabetes is related to 9 out of the 10 top 10 causes of death in the United States. So what happened those few decades ago that really started to push diabetes as an epidemic in our country and ultimately the world? You can see this is from the NIH. This is this sharp curve or change that occurred around the 1977-78 timeframe. And you can appreciate that in the middle there with the obese population, it started climbing significantly. The extremely obese followed that. And so we end up with these very big numbers. But what happened in 1977, 1978? Well, this is one thing that happened in 1977. The food guide pyramid came out, and people started following these instructions, stopped eating dietary fat, and started eating more bread, cereal, rice, and pasta. The food guide pyramid also made dairy a challenging group to figure out where to eat, and then started eating probably more fruit, more so than vegetables. The prevalence of obesity as a result of that started going up and up and up. And if you follow these charts, you can see this dark red just continues to spread throughout the country and ultimately the world. So, how are diabetes and obesity related? We kind of probably in your minds put them together as if they're one and the same thing, but they are certainly not. There are plenty of people that are obese that are not diabetic, and there are people that have type 2 diabetes that are not particularly obese. They are associated, though, and it used to be thought that a little bit of weight gain after the age of 18 was actually healthy. It showed that you were in good metabolic state. Dr. Willett from Harvard published a study that countered that argument and put actually some numbers on the weight gain and said that, look, if you gain up to 17 and a half pounds, your risk of type 2 diabetes goes up by almost 100%. When you gain up to 25 pounds, your risk increases by 270%. So there was a clear relationship, and it wasn't linear. The more weight you gain, the more likely you are to suffer the metabolic complications of diabetes. So, um, to understand diabetes, we really need to get a feel for the components of it. So, for example, insulin is the hormone that we talk about with diabetes, not exclusively, but it's the main player. So, we in general will talk about insulin from a treatment standpoint. You know, do you require insulin? Do you not require insulin? Um, the type 2 diabetics generally start out not requiring it and then eventually requiring it if it's progressive. Again, type 1 diabetics need it right out of the gate because they don't make it. But what is it? So, insulin is a hormone, meaning that it is a signaling molecule in your body and it tells your body to do something. Insulin, as a hormone, tells blood glucose, so the sugar that's in your blood as a result of what you eat or what your body does to make energy, that sugar gets pushed into your cells, all cells. Your fat cells, in particular, though, insulin will tell your fat cells that they need to hold on to energy because they are in a storage state. So they are literally in storage mode, or what we like to call the fed state. Insulin, as a result of eating, it can either go up or not go up. So, for example, if you eat carbohydrates, you will find that your blood sugar goes up and your insulin goes up. If you eat protein, your blood sugar may go up depending on how much you eat of it, but your insulin will go up in response to eating protein. Dietary fat, however, your insulin will not go up because your body does not require insulin to store or break down dietary fat. So, what happens if you stop eating with insulin? Well, your blood glucose will drop, your insulin level will drop. You will start breaking down that stored energy of glycogen. And ultimately, your fat cells can start burning fat for energy because the insulin is out of there. It is literally the gatekeeper of burning fat. And when it is present, you cannot burn fat out of fat cells. It is literally impossible. So, how is insulin related to obesity? Well, there is a relatively linear relationship. If you look at your blood levels of insulin when you're fasted, meaning that after you haven't eaten overnight, people that are not diabetic and not obese will have a very low level of fasting insulin. And these numbers are made up. This is just to demonstrate the point. If you then move to somebody who is not diabetic but is struggling with obesity, their fasting insulin levels will likely be higher because of the metabolic component of obesity. And I'll get into that in a little bit. If you're pre-diabetic and struggling with obesity, your insulin levels are going to be even higher. And then ultimately, in somebody who's diabetic, their fasting insulin levels can be very, very high, particularly if they're taking insulin to control their blood sugar, their insulin levels can be remarkably high. So, why is that a problem? Well, hormones are designed to be pulsed. They are signaling molecules. So, your body will secrete them from wherever they come from. They will enact a change and then they will be removed so that those receptors can then close down and then wait for that hormone to come out again. When they're constantly present, as in the case of chronic feeding, meaning that you eat all the time, if insulin is chronically present, then we develop a problem. So this idea of eating, particularly a low-fat diet, which encourages eating constantly because you're always hungry. If you're eating a snack every hour in a meal, 5 or 6 meals a day, so that you're never hungry, your body is always in that fed state, meaning that you are always trying to store food because you're always consuming food. Um, that is a challenge because those receptors for insulin then become what we call resistant to the effect of the insulin. If it's always there, the receptors start to ignore it. We term this hyperinsulinemia or insulin resistance. And this is really the underlying concept of type 2 diabetes, which I think is missed by most people and even a lot of physicians. Um, the cells are literally full of glucose. There's nowhere to put them. It is like a subway train that is packed full of people, but there's people on the platform and they're trying to get in. The doors open just fine, but you can't get in because it's full. So we know that there are some medical conditions that can mimic this that we could learn from. So an insulinoma is a medical condition where you have a tumor that makes insulin inappropriately. It makes it constantly, not in response to feeding. An insulinoma will cause weight gain and cause blood sugar to drop. These drugs, TZDs, they are diabetes medications, oral medications, and they do the same thing where your weight will go up, your blood sugar will go down. So if we think of the cell being full, you can kind of think of it like this sink. So it's an overflow phenomenon, meaning that right now, if you look at the picture, the sink is full of water, but the faucet's on. It's going to continue to overflow. It's going to run off of the counter. It's going to destroy your floor. So the cells are like that, right? The cells are full of glucose and the receptors are open. In order to get the blood out of, or get the glucose out of the blood, you have to empty the cell somehow, or add more insulin. And that's what the body does. So your body throws more insulin at the problem, and right out initially it works. Right? If you increase your insulin, increase the signal, you can actually shove more people into that subway train. But eventually you run out of the ability to do that, and your insulin levels get very, very high. And your cells are then resistant to insulin. So have we proven this in the literature? Are there studies that support this idea? There absolutely are. So if you infuse insulin to somebody, meaning that you actually drip insulin into their bloodstream, you can cause insulin resistance in as little as 40 hours. 96 hours, you can notice a significant increase, up to 40% of insulin resistance. So imagine if you can do that clinically in a couple of days. Imagine what happens over the course of months, years, or decades of having high levels of insulin. You can see why diabetes is such a quickly progressing disease, because the cells respond to that high level of insulin relatively quickly. So this is actually an accepted model of obesity. And we tend to think, particularly in America, we tend to think that obesity is an energy problem, meaning that we eat too much food, or we exercise too little, or we're just darn lazy. There's an entirely different idea out there of the hormonal or the carbohydrate insulin model of obesity. I have an entire lecture on this, which I'll do at some point. But the idea is that there are changes in the body that result in the changes in eating and activity. And if your body is secreting more insulin, or your insulin levels are high, it is going to have an effect on how you feel. It's going to have an effect on cravings and hunger, and how you eat. It's going to change your hormonal axis to change your behaviors. It's not the other way around. You're eating more, or you're working out less because of the changes in your body. You're doing those things because you're becoming obese. You're not becoming obese because you're doing those things. So this is an accepted model, but it has been challenging to watch our clients learn this when the traditional medical response is typically still that of energy balance, and that you're eating too much and you need to work out more. So what happens when you have high levels of insulin? Well, we've talked about diabetes, right? We know that people that have high levels of insulin and glucose have diabetes. But before you get to that, we mentioned prediabetes. Before you get to that, there's this thing called metabolic syndrome. It essentially pre-diabetes, and there are some clear objective things that go along with it. The interesting thing is that all of these things, elevated blood sugar, elevated blood pressure, abdominal fat, and cholesterol abnormalities, are all related to insulin resistance or hyperinsulinemia, not necessarily the other things that we are taught in general about them. All of those things are associated with heart disease, stroke, and diabetes. It's a big deal. If you look at the diseases of Western lifestyles, 5 of the top 10 causes of death are all related to insulin resistance, with tremendous cost to our system. So if you're diabetic and you go online and you're looking for the answer, you'll find these web pages that have principles and lots of support that you can look at. But the challenge is that the support that they show, I think, is misguiding for a lot of people, and that the nutrition approach in particular is very misguided, or it's hard to understand, or it's very, very vague. And if you look at the medical treatment, it is almost exclusively focused on lowering blood glucose, and for good reason. Elevated blood glucose, it will potentially kill you. It'll cause a lot of problems. it's the only thing that we as physicians have a medicine tool to treat, or potentially as a surgeon, a surgery tool to treat. Now, we will always recommend, if you go to your primary care doctor, lifestyle changes. And if you look at the ADA recommendations on that, they say, based on the energy model, focus on diet, aim to have a calorie deficit, eat less, and then move more. And then if that doesn't work, which it won't, and I have some studies to back that up, then you take oral medications and then insulin. So we'll go through that after we look at these recommendations. So the ADA, well-meaning, has, again, a lot of information, but it's relatively vague. It's hard to look at this and know exactly what I should eat. And the recommendations have started adding some things like dietary fat back in, which I think is great, but has actually made it even more confusing to understand, what do I eat? How do I actually treat this from a nutritional standpoint? The USDA MyPlate, which replaced the food guide pyramid, didn't really change much, other than make fat impossible to find on the plate. And maybe allows you to eat a little bit more. But again, if you look on the plate of the USDA MyPlate, it's not even on there. Maybe it's in the dairy. The type 2 diabetes guidelines for nutrition were established in 1977. And before 2015, very high in carbohydrates, 60% recommendation to eat carbohydrates, and then 30% protein, and less than 10% of fat. That is a very low fat diet, very hard to follow. In 2015, they released some of the restriction on dietary fats and said, no, it's okay to eat healthy fats. Didn't really define what that meant, but then continued to say you should eat 12 to 1500 calories a day and exercise. If you add dense, healthy fats to your diet and you're aiming for 1200 calories a day, you're going to eat almost nothing. So a very, very challenging diet to follow. And if you look at the massive studies like the Nurses Health Study or the Women's Health Initiative, these studies were huge examples of an intervention of a low-fat diet. And what they found is that the consumption of dietary fat really had no relation to heart disease or stroke. But they also found that they didn't lose any weight with the intervention. The low-fat diet did not produce appreciable weight loss in either of these. And these are over tens of thousands of people, millions and millions of dollars. They didn't lose any weight. The exercise didn't really seem to help. So there are multiple studies that looked at that, and they really just continue to fail to prove that the energy balance theory of weight loss is effective for anything other than making people hungry. So if you look at treatment of diabetes, so if you take that information, you say, restrict your calories, try to exercise, aim for this calorie deficit, that's essentially what diabetes education is. And this is a study looking at 5,000 patients in 2012. So if you look at that group, and I apologize, it's a busy slide, but I'll point out the important points. If you look at that group from a weight loss standpoint, 0.8% weight loss after a year. So after a year, they lost less than 1%. I believe that's of body weight. And then that was kind of maintained at 4 years. From a diabetes standpoint, though, 2% saw remission at 1 year, 2% of that group. And then less than 1% actually were still in remission at 4 years. So they could not continue to keep their diabetes in remission based off of that intervention. So this study from 2019 looked at data from 05 to 16, and their conclusion was it appears that the diabetes care cascade in the United States is not significantly improved between 2005 and 2016. And in fact, diabetes rates were skyrocketing in that time frame. And it's really unfortunate that the care that we're providing that is costing billions and billions of dollars is failing to improve our diabetic patients. All right, so if we look at treatment of type 1 diabetes, this is where the concept of how we treat diabetics really started. With a type 1 diabetic, you put them on insulin, and this is a study that looked at treating type 1 diabetics with insulin. And what they found is that things like retinopathy, which is the eye complications, nephropathy, the kidney complications, neuropathy, the nerve complications, all of those got better with treatment of insulin, and they didn't die from not having insulin. Unfortunately, they developed obesity, metabolic syndrome, and hardening of the arteries. Essentially, they became type 2 diabetics because they were being treated with insulin. They went from having low insulin and high blood sugar to having high insulin and maybe good blood sugar. But because of the high insulin, they essentially developed type 2 diabetes. So this study in 2008 was looking at complications from diabetes, and what they identified is that the high A1C, or high blood sugar, was not a factor in complications. In fact, metabolic syndrome, which I already mentioned is a result of high levels of insulin, was most significantly related to the complications of diabetes. So are we treating the wrong target? Well, this is another study on type 1 diabetics that looked at 400 patients that had survived over 50 years with type 1 diabetes. So, uh, you know, decades ago, this was impossible. Type 1 diabetics didn't live this long. But this was a group of patients that survived. And if you look at their numbers, their blood glucose control was actually not very good. Their A1C was elevated compared to current standards. Their insulin dose, however, was low. So these are patients who were able to maintain their blood glucose level and not take very much insulin. And the theory is that that allowed them to be to survive and do well over 50 years with type 1 diabetes. So the question is what should we be treating? Should we be treating the glucose or the insulin? I would argue we should probably consider treating both. However, medically, we don't have a pill that will reduce insulin. And if we're using insulin as a drug, clearly we're not reducing insulin in type 2 diabetics. So if you look at the treatment for type 2 diabetes, this was a study out of the UK that looked at 4,000 patients over 10 years, and their treatment intervention was with insulin, the injection, and then multiple different uh, oral medications versus the standard treatment in the UK. And the intervention group, they noted really only weight gain because of the insulin, no change in coronary events or heart attacks, and a little bit of improvement in the retinopathy, which is the eye problems associated with diabetes. This is another huge study that looked at a very intensive treatment of trying to get the A1C very low. That's a very tight glucose control compared to conventional, which is less tight glucose control. And they actually saw a much higher mortality rate in the group with very tight glucose control. They actually canceled the intensive arm of that study because they couldn't ethically continue to carry on the study because they found they were harming people controlling the blood sugar that well. Other studies, Advance, Origin, these are all huge trials that continue to fail to improve outcomes of diabetes looking at glucose control. So these large studies with a goal of lowering the blood glucose did improve things like retinopathy, but they did not improve things like heart attacks. You could argue they're both important, but heart attacks are, obviously the life-ending and life-changing events from diabetes. They also found that the treatment produced weight gain, and there's some issues associated with that. So why is it that we treat people with these drugs if they're causing weight gain and they're not preventing things like heart attack? Well, the reality is that as a physician, you have to treat high blood sugar, and you can make recommendations for lifestyle modification, but physicians in general don't have great tools to help people do that. And so their only solution then is to provide medications. The class of medications that we use for diabetes, they're all designed to bring down blood sugar, and they're grouped by how they affect insulin. And just to give you an idea of how much of these we're using, in 2015, there was a $23 billion market for insulin and these oral medications. So that's pretty significant. So there are a bunch of drugs that will increase your insulin level in it with an effect to try to reduce your blood sugar. However, if you look at the studies on these drugs, they do not improve the rate of heart attack. Some of these drugs are associated with bladder cancer and other side effects. This is a newer class of drugs that actually does lower insulin. And as a result of that, they actually don't improve your A1C or your blood sugar all that much. But they do reduce the risk of death, and they do reduce progression of kidney disease, and actually can generate a little bit of weight loss. Not a lot, but enough. However, nothing is for free, and there are complications of taking these drugs as a result of the way that they work. But potentially better than trying to reduce your blood sugar by increasing your insulin levels. There are some other drugs that have some significant side effects which just aren't well tolerated. So in general, insulin toxicity, or if you look at patients that have high levels of insulin use, just that drug is associated with an increased risk of having a cardiac event or a heart attack. That's scary when you consider that 1/3 of the diabetics in the US are using insulin. So what about surgery? Well, I'm a surgeon, so I can appreciate that surgery is sometimes, I'd like to think oftentimes, the answer Bariatric surgery has been adopted by the American Diabetes Association as a standard treatment option for type 2 diabetes. If you look at the literature, I can see why. There are some studies that would demonstrate like up to a 40% improvement in diabetes after a year from bariatric surgery. So that's pretty darn good. Many of those patients that did achieve remission. However, as I said with the medications, particularly with surgery, nothing is for free, and there are always potential risks, complications, and side effects of having to change the way that your body absorbs food or doesn't absorb food, as the case may be. So one of those things is anemia, meaning a low blood level and your ability to carry oxygen. Almost 2/3 at 3 years were struggling with anemia after bariatric surgery, B12 deficiency in a third of patients after 2 years. And then there's the weight regain, because you're not really addressing the nutritional or the behavioral components. You're simply forcing the body to make these changes. Now, there are some good programs that try to do this. I'm not saying this is true across the board, but if you simply do a surgery to try to force this change, they will lose weight. They might not lose enough weight, but the complications are potentially there. The risks and the side effects are there, and the weight regain, if you don't address the behavioral and the nutritional components, the weight regain is a huge problem. So I don't say this lightly, but medical treatment for diabetes is really failing stopping the progression. It's really absolutely failing reversing diabetes in general. And if you look at how some people have reversed diabetes, you can see why. Because we're looking at it the wrong way. We as physicians are mostly looking at the blood sugar, controlling the blood sugar, and then telling people they need to do dietary lifestyle changes, which are misguided and likely not going to impart much change. So if we look at curing diabetes from an overflow phenomenon, meaning that the sink is full of water, how do we shut the darn thing off? Well, the answer is you got to shut the darn thing off. So if your cells are too full of sugar, you got to stop putting sugar in the body. I don't mean just eating table sugar or eating, whatever your favorite snack is. I'm talking about carbohydrates, complex carbohydrates. They all break down into sugar in the bloodstream. And we'll talk a little bit more about that. And then you got to empty the cell. So how do you empty the cell? Well, for most people, they would say, oh, that means I got to exercise. Dr. Lucas, you just said that exercising wasn't the answer. Well, it's probably not the answer for most people that are metabolically damaged enough to struggle from diabetes. Most of my patients that have severe diabetes and complications from diabetes cannot exercise their way out of a full cell of glucose. So the other ways to empty the cell are dietary in nature, and we'll talk about those. So if you were to consume a diet that was lower in carbohydrate, in other words, stop putting the sugar in, and higher in dietary fat, that is one potential tool. Also, nutritional ketosis is another potential tool. Exercise, like I said, it's a tool. It's maybe not the right tool for a lot of people. And then meal timing is a very powerful tool, which we'll talk about. Ultimately, fasting is the longer version of meal timing, and we'll go through that real briefly. So the JOSLIN Diabetes Center, this goes all the way back to the beginning of the talk. The gentleman who coined the term in the United States and literally wrote the book. The JOSLIN Diabetes Center adopted carbohydrate restriction in 2005. They reported in a study that they had lost over 10,000 pounds in their patients and that they had been reversing diabetes in many of their patients. The ADA actually updated their guidelines in 2019 and said that low carbohydrate eating plans show potential to improve glycemia and lipid outcomes, meaning that your blood sugar might get better and your cholesterol might get better at a year. They quoted 7 studies, which I looked at, and further studies will, I think, continue to demonstrate improvement. But at least that foot is in the door at the ADA. There's some very compelling literature on nutritional ketosis, and this is a tool that you have to use carefully, particularly if you are diabetic. And I'll talk more about how to work with your physicians. But nutritional ketosis is what this study is based off of, and that's essentially teaching your body to burn fat as a fuel rather than glucose nearly exclusively. And this was a study on 262 patients. They had none of the feared ketoacidosis complications of putting people in nutritional ketosis, which we're all taught as physicians. They lost some weight, not a ton actually, and that goes to show that reversing diabetes does not mean that you have to lose all of the weight, though I'd argue that in order to keep it off, that you do. Their insulin use decreased by 94% or stopped completely. So 40% of their uh, patients were able to stop insulin altogether, and 60% decreased by half. Glucose improved, insulin improved, all of their measures. I mean, just everything got better as a result of this nutritional change. And 60% remission, which, if you remember the study I talked about with traditional dietary education of what was it, 0.3% or something of remission, 60% remission is something that I would be proud to say, yes, my approach works. But what about fat? You've been told your whole life that you probably shouldn't eat fat and that fat will make you fat and that fat will sludge up your arteries and cause you to have a heart attack. Well, I would say that that's not true. Lots and lots of evidence to appreciate that. So let's look at a few different things. So eggs, we've been told not to eat eggs because of the cholesterol. Well, actually, eating eggs is associated with a reduction in diabetes by a significant amount. Full fat dairy, eat full fat dairy. It reduces your risk of developing diabetes by 60%. It is shown to lower inflammation and improve your cholesterol measures. Nut consumption, full of fat, right? Don't eat it. Just kidding. You should eat it. It reduces your risk of heart attack. These are all associations, but it gets a point across. Dietary fat does not promote the secretion of insulin. The hormone is not secreted when you consume dietary fat alone. This is a meta-analysis from 2009 looking at the Mediterranean diet. And what it showed is that the healthy fats of the Mediterranean diet are protective of heart disease and stroke. And this was a nice study by the author, Zoe Harcombe. She's a PhD that has some great articles and books, actually. And this was a meta-analysis demonstrating that the current recommendations and guidelines are not supported by the evidence. And this was over many, many studies and thousands of patients. So if you accept that it's okay to eat dietary fat, what about this fasting thing? I've been told that if I fast, then I'll go into starvation mode and my body will shut down and I'll die. Well, if you look at the studies on fasting, it's really interesting. And if you think about it just from a historical standpoint or an ancestral standpoint, even, if you were running out of food and you were a caveman, you would consider that certainly a food shortage and a crisis. You need to be able to respond to that crisis or you would perish. The hormonal response then should be to increase your stress hormones, maintain your muscle mass. You want to eat your muscle mass, maintain what's called the basal metabolic rate, or BMR. That is the amount of energy that you consume just sitting at home being you. All of those things are maintained. Starvation mode, quote unquote starvation mode, is the opposite. It is the lowering of the basal metabolic rate, consuming your muscle mass in order to just survive. That occurs over a long period of time of chronic starvation. And really, by definition, starvation is the forced reduction of food consumption, whereas fasting and intermittent fasting and time restricted feeding are all voluntary restriction of calories and food for a certain period of time. So a couple of studies that look at fasting. Intermittent fasting demonstrates a significant drop in your basal or your fasting levels of insulin, and then your basal metabolic rate, that BMR, does actually go up in intermittent fasting studies, meaning it's the opposite of starvation mode. If you compare fasting to a true low carbohydrate, high fat diet, as I mentioned in the other study, they're similar. They both improve glucose, insulin, other hormones, but the dietary approach of nutritional ketosis was only 71% as effective as fasting and improving those measures. So if we're trying to talk about getting the weight off, improving your diabetes, how do you stay there? That is the holy grail of weight loss. Is you can lose weight in any number of ways. I mean, there are I've lots of talks on this. There are lots of ways you can do it. Very few of them are particularly healthy, and even fewer of them are sustainable over the long term. there are some keys that you need to consider when you're looking at a program on how to lose weight. Um, because to keep the weight off, you have to do a few things. One is maintain your lean muscle mass. If you were 400 pounds and you got down to 180 pounds, you would lose some lean muscle. It's expected. You don't have to move around that much weight. However, there is a shift in the amount of lean muscle mass that you lose if you lose that weight inappropriately. I put this picture of the Biggest Loser on there because it is the epitome of the energy balance theory of weight loss. And if you look at those contestants, and I have a blog on this in the research corner, I'd encourage you to read. If you look at those contestants, they did lose a tremendous amount of weight. There's a study that looked at a 7-year follow-up and demonstrated that almost all of them had gained all of their weight back or more. Their basal metabolic rate, that rate of burning calories just by being you, not only didn't come back, but it actually continued to worsen because of the approach. Severe caloric restriction and exercise does not allow for weight loss maintenance. So maintaining lean muscle mass. Fasting, if you fast, is not associated with the risk of weight regain, probably because you're maintaining your lean muscle mass in other ways. Low carbohydrate eating and fasting will increase your basal metabolic rate, meaning that rate will actually go up if you use these tools. If you understand your carbohydrate tolerance level, meaning that gosh, my kids can eat this food, but I can't. I am metabolically damaged to a point that I cannot consume this. I know how much I can consume, then you can keep under that level, whatever that level happens to be. Being metabolically dynamic, meaning that your body knows how to burn fat, and you know how to tell your body it's time to burn fat. And you can do that with your tools of eating, and you can do that with your tools of intermittent fasting and time restricted feeding. Maintenance weigh-ins, I think these are critical. It is so easy to creep up over time and not really notice it until all of a sudden you've put back on 50 pounds of your 150 that you lost, or 50 pounds of the 50 that you lost. And you didn't really notice it, or you were too ashamed to think about it. And the reality is that if you don't get your numbers, if you don't watch this, then you can't intervene. And the earlier you do it, the better. So I recommend that people literally, weekly, make it a habit. It's not negotiable. And ultimately, collapsing your visceral fat. That's the fat around the midsection. That's that measurement that you measure to look for metabolic syndrome without getting all the labs. It's the fat that is communicating with you. It's secreting hormones. It's creating inflammation. It is the fat that you need to get down to a sizable mass. And that's why I think that bariatric surgery approaches that don't allow for enough weight loss, or weight loss programs that don't get you down to the right point, they put you at very high risk for weight regain because that visceral fat is still there. So how do we reverse diabetes? After all that, here we are. Number one, carbohydrate tolerance. You got to know what yours is. And you must avoid fructose at all costs. For people that have been diabetic, that are metabolically damaged, fructose, which is a component of table sugar, sucrose, fructose has a very different metabolic pathway. It goes directly to the liver, causing fatty liver, and it will make your insulin resistance worse, and it will make your diabetes worse. You have to avoid refined carbohydrates because it is just punishment for your cells. Your body doesn't know how to tolerate them. Enjoy natural fats. They are delicious. It makes cooking so much better to be able to use dietary fat. And eat real food. Get away from the processed stuff that's in the middle of the grocery store. Stay out of the aisles. Stay in the periphery. Eat real food. Cook real food. And use hormonal diet tools. Fasting, intermittent fasting, time restricted feeding, carbohydrate restriction. If you're currently diabetic, talk to your doctor. Do not use these tools without saying to your doctor, hey, I'm going to do this thing. I might need you to change my medications, because the reduction in insulin will happen in days or weeks, but quick. You'll need to take less pills. If you're on insulin, you'll need to get rid of your insulin. And you have to do that with the aid of your doctor, because it's challenging. Insulin is a confusing topic, even for a trained professional. Do not do this on your own. And watch out for lows. Ultimately, lows can kill you. So while we do want you to see your diabetes reversed, you do have to watch out for lows. It is a real risk. And that's all I got. I want to say thank you to my wife, Dr. Ashley Lucas, founder of PhD Weight Loss and Nutrition, and the whole PhD family, including all of our clients and coaches and people that follow us on social media. These are our social media outlets, both Twitter and Instagram. Myself and PhD Weight Loss have accounts, and you can follow us on that. I would encourage you to check out our Facebook account, as well as, if you're a client, go to the client group. If you haven't been on it, we're really focusing on putting people in the client group so that you can share your stories, support each other, and help each other through this, particularly as we're all sitting at home and sheltering at home. It's never been more important than now to really reach out and support each other and help everybody to get through these times.